Let me share my presentation. You're able to see this?
Yes.
Okay. So I would be presenting on macular hole retinal detachment, which is always a challenge in most patients. But here, the challenge was much later. This is a 47-year-old lady of a myopia of minus 22. She has been on long-term follow-up, perfectly good health. She has no diabetes or hypertension, and she used to, I mean, she didn't look as if this had any systemic problem. Vision was 624 in both the eyes. Fundus showed some myopic degeneration with vitreous floaters. And but in July 2020, she complained of sudden blurring of vision in the left eye, and the vision had dropped to 3 by 60 in the left eye, and the right eye continued to be 636. At this time, when we see the fundus, you can see that there are myopic changes. There's a crescent and some focal myopic degenerations. But when we did the OCT, there is a dome-shaped macula with some subfoveal fluid. So assuming this to be the subfoveal fluid of due to the dome-shaped macula, I said, let's see. The other eye, the left eye, which had the symptoms, showed that there is a dome-shaped macula similar to what is there in the right eye, but you could see a macular hole and there was fluid in the entire inferior quadrant. And when we did the OCT, showed a small macular hole and there is subfoveal fluid. And we assume that, yes, there is a macular hole retinal detachment at this stage. And we took up for surgery. And this is the surgery. As you can see a lot of fluid inferiorly. And I first removed the hyaloid from the posterior pole so that there'll always be, there's no PVD. Most of the posterior hyaloid is adherent to the retina. So we need to remove it carefully. So after that, I did go about, removing the posterior hyaloid all over. We need to restain with triamcinolone fairly frequently. You can see that the retinal detachment is involving the entire temporal inferior quadrant. And it required a lot of, careful evaluation and peeling off the hyaloid, which did well. So I know because I did use a 25 gauge. This is a 25 gauge vitrectomy. Although it is minus 22, I could still reasonably do a good job with 25 gauge. Uh, so after inducing all this, the surgery is fairly otherwise routine. We peeled the ILM, and at the end of surgery, the retina flattened out and it was fine. Sorry. And on the post-op day, patient started improving. And once the gas disappeared, we could see that the hole was closed. There was a problem prior to surgery wherein we observed that patient had high blood pressure. But patient said that she has no history of hypertension. Anyway, we kept that in our observation. She had borderline random blood sugar. So we controlled the hypertension and the surgery was done, and the patient was given a reference letter to the physician asking her to see the physician because there seems to be some problem in her health. And but on the post-op day, in post-op 1 month, the retina was looking good. There was no subretinal fluid. The hole was closed. Everything was looking good. 15 days later, she came with some spongy thickening of the retina. Now you can see that there is spongy edema in one side of the maculas. The holes are continued to be closed. We said, let's observe this and see what's happening. She came a month later complaining that there is a dark patch in her field of vision, and the vision was still 6 by 60, but she's saying that I can see a dark patch. And when we see now, there is a subretinal fluid and a lot of edema, which is intraretinal edema with hyperreflective dots, which started appearing. So we know that there is some systemic problem that is occurring in this patient. So we asked her whether she had seen the physician, and she said, I have not at all visited the physician, although we had given her a reference letter. So at this stage, we advise that, let us go through all the systemic investigations. And to our surprise, we find that she was anemic with a HB of 7 grams. The HbA1c was fine. The ESR was high. She had a creatinine of 6.8. So we asked her to immediately see a nephrologist and to see that she's, undergoes complete evaluation and treatment. When she came back, she had seen the physician and they had managed the anemia. So her blood hemoglobin had improved to 11.6 and the hypertension was on control. And we now see that the retina started looking much better. The edema had disappeared. There was no fluid. So this is on the left eye. And the right eye, the subretinal subfoveal fluid, which was there, also disappeared. So now we come to an important thing that, we know now that a lot of the systemic condition was probably responsible for some part of her condition. But did it play a role in the initial presentation? Because now looking back, I think both eyes had some degree of fluid, whether that triggered the onset of the macular hole detachment, because we know that the inverted Muller cone cells are, tend to give way once there is some sort of a problem in some of these patients. So this is what.
I don't think that the initial thing was related to the hypertension, because I think in that case, immediately after vitrectomy, I had a rebound.
Good closure.
Yeah, exactly. So I think so. But you're lucky that the patient did not have any intraoperative problems, systemic problems, emergency during surgery.
Yes.
I mean, controlled blood pressure and anemia and high creatinine. So that way, I think you're fortunate with the
We
patient.
enjoyed your surgery, Hemanth.
Yeah.
It was good.
Yeah, very nice. So Raja, how do you take care of the post-operative CME in addition to the systemic control of the factors which Dr. Hemanth nicely showed? How do you deal with the post-op CME?
Yeah, so this was not just a post-op CME. I would like to just, I don't have an exact diagnosis, but my first thing would be to do a fluorescein in this case when you saw that edema, and not OCTA. I know you may have comments on Opta, but I would not believe in Opta in this case. Definite fluorescein, look at probably one of my differentials would be a macular branch occlusion. And sometimes in such high myopes, it's not easy to pick up. But I think it's one differential. I can't say that it is the case. But fluorescein will tell us where's the leakage, what kind of pathology. I'm suspecting a vascular pathology, looking at the kind of edema, the localized edema, high reflective dots. Sometimes in these patients, it may be easy to miss small vessel occlusion. But overall, I think the surgery was done very well. Sometimes you do get these edema, if you get back, then it can cause reopening of macular holes, especially if it's a CME kind of thing. But you're fortunate that it has not happened so far. I don't know, what was the treatment that you gave? You showed us some investigations, systemic, but how did you manage it?
No, the management was done essentially by the nephrologist. So they started controlling the blood pressure first, and they said that she would have to undergo dialysis. So prior to the dialysis, she came to us and she started showing improvement just with control of hemoglobin and the blood pressure.
Wonderful case, Hemanth. Wonderful case, a lot of learning